I am happy to answer questions. If I don't have an answer, I can get the answer back to you. But thank you very much.
Fantastic. Thank you very much, Dr. Chan. We did have quite a few questions that came through the queue during the presentation, so we'll turn over to those right now. So the first question that came through, Dr. Chan, you mentioned a while back towards the beginning of your slides, conducting bedside insertion. Given the current situation that we find ourselves in, do you mind walking through briefly how you would place a bedside PD catheter blind?
Yeah, so to place a catheter blindly bedside, previously, I'm talking about 20 years ago, you would just use everything in the kit. You would prepare the patient sterilely, you use chlorhexidine or povidone iodine, prepare the abdomen, shave it if you need to, and then you would measure where you want the catheter purely based on where the curl is, the intraperitoneal curl and pubic symphysis, where you want the catheter is and where you want the exit site. Then you will do your perimedian incision, and I would recommend ultrasound if you do it bedside. You can look for the vessels clearly, and then you need to make your incision, and the incision can be 2 to 3 centimeters in length to the anterior rectus sheath. Once you're at the anterior rectus sheath, you'll do pretty much the same thing, unless you have a C-arm there, exactly the same thing that I talked about. If you use a blunt Hawkins needle or whatever needle you're using, you may need a little nick into the, tiny little nick into the anterior rectus, and then you can feed, and you'll feel that pop once you get into the peritoneum. Then you feed your wire. So if you don't have fluoro, if your wire is not feeding, then you need to redirect the needle. If it's feeding, then most likely you are in the pelvis, okay? Because if you're in the bowel, it is not going to feed. That wire will not feed. Or if you're sub-Q, or you're not past the posterior rectus, you're in the rectus, the wire is not going to feed. But when you're in the pelvis and it's feeding freely, then you are most likely in the pelvis. You may be a little lateral. But in my experience, if you're a little lateral to the left or right, it's not really going to cause an issue in terms of performing peritoneal dialysis. Once your wire is fed in, then you can use a dilator like we use, or you can dissect a little bit into the rectus and feed that sheath. The sheath should go in easily. And once your sheath is in, you do the exact same thing and just feed that catheter in. Obviously, you'll get an X-ray just to make sure you're done with the procedure. To make sure it's in the pelvis. Again, if it's left or right, you still can do PD. It's really based on surface area and how much contact the dialysate has with the peritoneum and the peritoneal vessels, the microvasculature. Ideally, if you have a C-arm, then you can inject contrast. You know exactly where your catheter is. But again, if this is urgent, if resources are limited, you don't want to expose too many people, and you're going to have to do it blindly and bedside. But again, if you're using a dull needle or you're using a 21 gauge needle, I feel it's very safe.
Perfect, thank you. We received a couple questions surrounding extended catheters or upper abdominal catheters / pre-sternal catheters for more obese patients. Can you walk through the indications for a external or upper abdominal placement? And are there any studies that compare the outcomes of just your standard placement versus an upper abdominal or pre-sternal placement?
From what I understand, there's not that many outcome study on it, but in terms of catheter types, whether you're doing a modified pre-sternal, there's no difference. The incision or where the catheter goes in is exactly the same where it goes in with a normal catheter, a normal length catheter. The only difference in a substernal or a pre-sternal, or a modified pre-sternal, which is what we do quite a bit in patients that don't want it right at their belt line. They want it higher, so I have it pretty much right at their rib cage, and they can reach there and connect and disconnect easily. The only difference is you have a connector, like a titanium connector um, between the catheters to make it longer. And then the tunnel is actually longer as well. So that's really the only difference. When you get up to that area, you still need to make that exit site downward facing or lateral facing. You can't have it straight up, and that's contraindicated. But again, it's patient preference, and it's also, in obese patients, they may have trouble in terms of, pannus, etc., connecting, disconnecting where that catheter lies. And so a lot of times in those patients, we'll just do a modified pre-sternal. I know St. Louis University, Kevin Martin, they do pretty much all pre-sternal, and that's their center preference. So it really is center dependent. It does take longer, and so if you want to save time, we don't do it. I mean, if you just have to keep that in mind, it does take longer to do a pre-sternal catheter.
Great, thank you. And now transitioning a little bit more to your fluoroscopic technique on insertion, how do you know where the deep cuff is using the fluoroscopic technique?
The fluoroscopic technique, if you overlay the catheter on the body, you'll see where the deep cuff is, and that's pretty much where your cuff is going to go into the rectus. And so you want your catheter lying in the pelvis, and again, the top edge is going to lie usually flush with the pubic symphysis. That's why I talked about the retractor. You need a retractor because you need to see exactly where the cuff is. Once you put the catheter into the sheath, the peel away sheath, that cuff is going to lie right at the peel away sheath. And once you start peeling it away, you want to push your internal cuff flush against the anterior rectus sheath. And then you do want to bury that internal cuff into the rectus. So you want to usually it requires a little dissection, and you just push it in. And once you can't see that cuff, then you know you're buried and you're good to go. And again, I recommend doing a purse string, and usually we use, 2.0 vicryl, usually CT, it's a little better bite. And we just do, 3 bites, a purse string over the catheter there. And then you do prevent a pericatheter leak by doing that. So you can't just throw in a pigtail catheter like for a drainage without cutting down to the rectus sheath because there's risk for infection, etc. I know some interventionalists, they will just dissect, and then they will just put that cuff into the subcu fat and not necessarily bury that. It can work, but again, you may have leak if you do that.
Perfect. Okay, thank you. And we've got 2 more questions here. The first question is related to the insertion itself, and it asks, what is your experience using a transversus abdominis block, as the insertion can be a little bit troubling for patients under moderate sedation?
I honestly have not used that, but if you can use that, I guess, that's definitely another way of providing anesthesia. In my experience, if you give lidocaine sub-Q, and then we actually have the Valsalva, do a Valsalva, and then inject more lidocaine down into the rectus. With Versed and fentanyl, we don't have issues. with discomfort. And that's how we've done it for 8 to 10 years. But
Okay.
if you can do that, that's great. I've not had experience with that.
Okay, thank you. And then we actually just received one more question, so we'll do two more. Can you briefly walk through just the removal of the catheter?
So yeah, that's important too. So say a person has recurrent infections, Pseudomonas peritonitis, fungal peritonitis, or they're just going to get a transplant, or they're going to hemodialysis. You do need to remove the catheter. And again, to remove the catheter, you can't just pull it out. So you do have to, again, make an incision. And if you place that catheter, you know exactly where that incision is. So you make the same incision. You need to dissect down to the anterior rectus. And then you need to, with manual, pressure, pulling on the catheter, find that interior cuff and dissect the fibrous tissue. Once you dissect all that fibrous tissue, the scar tissue, then the catheter will come out easily. And so the biggest problem is getting to that cuff. I mean, it's very easy. And some people just have a lot of scar tissue. It can take a little time, but that's exactly how you take the catheters out. And we take catheters out that are replaced years by surgeons, etc. Don't have an issue. You just really need to find out, find that cuff and dissect the tissue around that cuff. So it can be a little bit more tedious, and that's the word, tedious than hemodialysis catheter removal. That is very superficial. You know exactly where the cuff is, and again, but the fibrous tissue that you dissect is very similar to the peritoneal fibrous tissue.
Great, thank you. And we've got one more question here, and then I will wrap up the call and discuss how we will have this presentation available for anyone who might have missed it or for distribution. So this last question is more overarching, just looking at the PD marketplace within the US as a whole. Do you feel that PD catheter placements will shift more towards the interventionalist and away from surgical placements post-COVID-19 looking long-term? And same for care setting. Do you believe that more placements would be done outside of the hospital post-COVID-19?
I'm not sure how COVID-19 is going to influence it. I feel that already that the rates of peritoneal dialysis were increasing pre-COVID-19, and the new NKF KDOQI guidelines came out really pushing for peritoneal dialysis, i.e. home dialysis. Home hemodialysis is still very minimal, but home dialysis and the training incentive that CMS has placed on it, Percutaneous and DaVita, which are the large dialysis organizations, are really looking at having at least 40 to 50% of patients on peritoneal dialysis. And so really the only way to increase, well, one of the big ways to increase peritoneal dialysis is for interventionalists to do it. And so, many colleagues and people that don't know across the country are asking about training, about placing PD catheters, because nephrologists are referring more and more to interventional radiology to place these catheters. So I think important is just to place the catheter right, just to get experience. You haven't done it, you just have to try it and do it. Again, we do offer, training through Medtronic via, whether we do a WebEx and go through the procedure, step by step, or there might be other ways for, you to come to me or I to come to you, or other venues to do that. But placing the catheter right is key. To increase the number of PD patients, there's been many studies showing that if an interventionalist places a catheter you can increase your PD population. And that's what we've seen with our program, as well as Miami and many other places. Definitely, whether it was COVID-19 or not, but post COVID-19, we're going to see just a gradual increase. And also the cost savings. It saves CMS billions of dollars by doing peritoneal dialysis versus in-center hemodialysis. So that's a good question.
Fantastic. Well, thank you so much, Dr. Chan, for joining us today. If you have any additional questions or comments following today's webinar, please feel free to reach out directly